And it's now my job to introduce our first keynote speaker, Professor Dame Carol Proper. Carol is Professor of Economics at Imperial College Business School in London. And between 2016 and 2019, she was also the Vice Dean for Faculty and Research at Imperial College. Her research focuses on financial and non-financial incentives for the quality of healthcare and healthcare productivity. Very much hot issues these days. And more generally, she's contributed to the understanding of the design and consequences of incentives within the public sector and the boundary between the state and private markets in the provision of services. Now, Carol is a past president of the Royal Economic Society and has undertaken a wide range of public service activities, including, I just give you a few, chair of the ESRC Research Grants Board, member of the ESRC Council, member of the Royal Economic Society Council, and member of President Macron's Commission on Major Economic Challenges. I don't know how you manage all these, but you must have done, because they are inviting you back, so you must have been doing a good job. Now, Carol has received numerous honors and awards for her work, including a Damehood for her services to public health and economics, and a CBE for her services to social science in 2010. And these accolades recognize Carol's research into public economics and the economics of health and care, and her contributions to policy. She's a fellow of many learned societies that I will not list, but includes the British Academy and many others. Now, Carol's lecture is titled Choice, Competition and Quality in Healthcare. I very much look forward to hearing what you have to say. And at the end, hopefully after 40 minutes, and you will know if you've exceeded the 40 minutes, there is a Q&A, which I very much hope that you'll be able to participate. Thank you very much. Please, Carol.
Thank you, Chris, for such a generous introduction. And it's a real pleasure to be here and to be here in person. Having been the RES president at a period where, and the president-elect and the past president, where everything was online, it's really great to be here in Glasgow and see people in person. And the other thing is, obviously, you know, Glasgow is known for Adam Smith, but also I noticed that next door to this building is the Boyd Orr building. And Boyd Orr was a really important person in that he was a physician who started some of the really early cohort studies which have illuminated the impact of people's early lives on their past lives. Many epidemiologists, leading epidemiologists like George Davey Smith in Britain, made his name studying the Boyd Orr cohorts. So I think not many English people know that. Probably the overseas folk don't know that, but those in Scotland should really know who Boyd Orr is. So I'm going to talk about something that I've been working on for many years, and it's choice, competition, and quality in healthcare. Now, but I wanted to start with some facts about healthcare because I think it's kind of a useful backdrop to be thinking about why one might be interested in healthcare. The first is the graph that you can see on the top left. I don't know my left from my right, so I think it is the top left, which basically shows the percentage of GDP spent on healthcare in the last 20 years in a pack of OECD countries. You can see immediately a huge outlier. That's the US. There are lots of reasons for this. It's not that the US on average has much better health than the UK does, but it does have some outstanding healthcare. But anyway, it spends a lot. But what you can really see is that the whole pack of OECD countries have all sort of an inexorable rise in the amount spent on healthcare. The second graph on the right-hand side at the top shows healthcare expenditure per cap across the OECD. And again, you can see that the US, which is this big outlier on the left-hand side, you can see the average. You can see that this varies quite a lot across OECD countries. The red bar in the middle is the average, and the UK, for those who can see the slides, whose eyesight is better than mine, is just next to that average. So the UK is kind of average. The bottom left-hand side shows you the government spending as a share of national income for a longer period for the UK. And you can see that there are bumps up and down, but essentially the trend is upwards, quite strongly upwards, between about 1990 and 2000, and then flattens and rises again. And finally, I wanted to kind of say that one of the important things about the healthcare sector is it's a big employer of individuals. The bottom graph shows you total health and social employment, so it's the social care sector as well in OECD countries. And you can see that that's a large sector of the economy. So whilst as economists it's quite right to be excited about things like AI, technology, which is important in healthcare, and other areas, I would contend that actually understanding how healthcare is produced is a really important part of the economy. It's a major part of what governments spend their money on. The US is projected to spend 30% of its GDP in 10 years on healthcare. So 1 in 3 people, essentially, will be in the healthcare sector, widely defined. So I'd argue that understanding how healthcare is produced, understanding the impact of technology on healthcare, understanding the incentives in healthcare is going to be important for production, but also for well-being. Because obviously one of the inputs, but only one of the inputs into well-being and health is healthcare. It's not the only input, and it may not be the most important input, but I wanted to give you a few facts about health. The first is that the median age of death is rising over time. We've just seen a brief drop in the last 2 years, in fact, in Britain, which is pretty shocking, but it has tended to increase. The second is that there are some sort of stylized facts about health that I'm not going to talk about, but are a kind of backdrop to this talk, which is first the increase in length of life that we can see across many countries. If we forget about the pandemic for a minute, the general trend is a decrease in death from communicable diseases and an increase in the rise of non-communicable diseases. Now, I think it is quite likely that we might have more pandemics for various reasons, but that's against the backdrop of non-communicable diseases, diseases that are essentially diseases of either lifestyle or diseases that occur because we're better at curing people from dying, but they remain ill. And the other thing to notice as a kind of backdrop is the increase in multimorbidity, which means that individuals as they age have not just one healthcare problem, but a number of healthcare problems, which makes them more complicated to treat. And the final thing that I think is very stark in this sector is gains in health are not equally distributed either spatially across countries or by socioeconomic status. And that's the kind of 2 graphs at the bottom. But as I say, I'm not really going to talk about health. I'm going to talk about healthcare, and they are different things. So, as I say, the healthcare sector is characterized by growth in expenditure over a long period, driven in part by demography, but not just by demography. It tends to outstrip GDP growth. The healthcare sector is also one in which there's a large amount of innovation. But innovation tends to be cost increasing as well as increasing quality. So although there are innovations which are cost decreasing, a lot of the major innovations in healthcare have also been cost increasing. So therefore, policymakers across the world are concerned about cost, productivity, and quality. So if you think about how you might tackle growth in healthcare, quite simply, as an economist, you could separate this into 2 sides. On the demand side, you could alter the incentives facing the consumer. On the supply side, you could also alter the incentives for suppliers, and many healthcare reforms do both. But on the demand side, if you think about how you want to restrict demand, at some point you want to essentially increase the price, be it monetary or non-monetary, of consuming healthcare in order to make consumers more responsive. The problem is that if you think about users of healthcare, many of them tend to be less well off. So widespread demand-side changes tend to have undesirable equity consequences, or if you put in things to deal with equity, you tend to then dampen that demand-side restrictions that you're trying to do, or demand-side prices. So the use is limited, particularly in the European context, where almost all countries in the European context use systems of regulated prices, and where the populations are covered by high levels of insurance, so that they don't essentially face prices. So in the European context, perhaps more even than the US context, the focus is on changing supply-side incentives to try and make supply more efficient and make suppliers respond to incentives, both financial and non-financial. So one favored reform that kind of comes and goes, I need to say that policy reforms tend to come and go in this space in terms of their flavors, but one favored reform approach, which is widespread across OECD countries, is the introduction of market mechanisms into what were heavily regulated centralized systems. The appeal of competition for politicians is quite large. Competition in the rest of the economy is argued to promote growth and has been shown by economists to do so. So there's a simple political appeal of competition in healthcare because many of them have essentially low productivity growth. On the other hand, if you look at the US, which is one of the markets that's most using non-competitive mechanisms to deliver care, or rather ideally would like to use competitive mechanisms to deliver care, there have been a lot of questions about the functioning of healthcare markets. So for example, in the US, you've seen huge increases in prices for healthcare. In the last 2 decades, prices for hospital services have increased faster than prices in any other industry in the US, despite technological innovation in that industry. Secondly, you've seen a significant rise in market concentration. Over the last period, approximately a quarter of all hospitals in the US merged, and the majority of hospitals have an HHI, a concentration index, of over 5,000, so defined as heavily concentrated markets. So there's a major concern that high hospital prices simply reflect providers' market power rather than investment in clinical outcomes or strategic investments in quality. So it's kind of against that backdrop that I want to ask, can competition bring gains in the healthcare markets, particularly with a focus on European markets? When you think about using markets in healthcare, you can think about using them both on the insurance side, because this is a risk that individuals prefer to be insured against, or on healthcare. Now, in terms of introducing competition in markets in healthcare, you can either promote competition in insurance or competition in provision, or both. So there are some countries like the USA, the Netherlands, and Switzerland that use competition both on the provider side and on the insurance side. Though I have to say that in Switzerland, the competition on the insurance side is so regulated. So for example, if I give you an example, every insurer has to offer every hospital as a choice for individuals to go to. So it's so regulated that it probably doesn't work very well. And in fact, it doesn't work very well. So if you think about a market in which you've both got competition on the insurance side, or markets being used on both the insurance side and the provider side, you've got a very complicated multi-stage model that's going on. First of all, providers make investments that determine quality. Secondly, providers are going to negotiate with insurers over price and the network, the number of facilities that are included for an insured person to use. Thirdly, insurers are going to choose insurance premiums, taking account the behavior of other insurers, particularly in markets which are monopsonistic. Fourth, consumers are going to choose insurers. Now they have a package to choose from. And finally, some consumers will get sick and choose providers either inside or, if they're allowed to, outside their network. Now that's a very complicated set of stages and offers an awful lot of interest for economists to work on. I'm just going to focus, for reasons that I'm going to talk about, on the first of the decisions, or rather, I'm going to focus on the link between provision and quality. So as I say, many reforms in using markets in healthcare use markets on the provider side only. So they have state insurance or no choice of insurance, either insurance funded by taxes or insurance funded, by direct taxes or social insurance, in which individuals have no choice of their insurer. A classic example is the NHS. And these countries have tried to introduce competition in healthcare. So examples are the UK, all the Nordic countries, Germany, Italy, and several post-Soviet countries like Armenia, Georgia, the Ukraine. So in this, I'm going to focus just on the first stage of the multi-stage kind of game that I was talking about before, in which I'm going to focus on quality determination in provider markets. And I'm going to ask, how is this influenced by horizontal competition, consumer information on quality, and the extent of choice they can exercise? So if we think about going to the theory, there are theoretical models of quality determination in healthcare, but many of the models are not very specific to the healthcare sector to date, though there is growing interest in thinking about theoretical models of quality determination in healthcare sector. Now some of the models have borrowed from education. The main difference with education is education markets and models of competition in education are very complex because individuals make residential decisions at the same time as they make investment in education decisions for their children. In the healthcare sector, most of the models tend to be a bit simpler because it assumes that residential decisions are exogenous to the healthcare decision in the main. So what do these models tend to show? These models tend to show that if you use a system of regulated prices, so that prices are not determined in bargaining between insurers and providers, but are regulated by some regulator and are set using a regulated price system that's kind of similar to some of the things that Ofcom and Ofwat and others have done in time. Competition is predicted to increase quality as long as prices are above marginal cost. And the idea is that you're only going to compete on quality, so as firms raise quality to attract and retain buyers, they will increase quality. Note, however, that has to be measured quality. It's quite possible that if you have aspects of quality that are not measured, what will happen is you have competition to raise measured quality and unmeasured quality falls. And in fact, I have some work that shows that's exactly what happens. This relatively simple prediction that competition raises quality holds when you allow for some more complex institutional features of the healthcare market, like firms with non-profit objectives, a subset of consumers who don't exercise choice, and indeed semi-altruistic providers, because this is a market in which you think that providers are not interested just in profit maximization, but in some aspects of caring about their patients with some weight. But the final thing to notice is that increasing quality is not necessarily welfare increasing, because firms are going to ignore, as in other analyses, the effects of business stealing. So you may have excess quality increases and that depends very much on how much you value healthcare as opposed to other goods. If you have market-determined prices, essentially most of the theory models show there are no determinant results when firms choose both price and quality. It essentially depends on the relative elasticities of demand with respect to quality and price for different consumers, because there will be different kinds of consumers in this market, and the nature of competition between firms. So it becomes very complex the minute you allow for both price and quality negotiations. Where consumers are fully insured, competition is likely to increase quality because demanders are not going to be very responsive to price if they're fully insured. And in equilibrium, greater competition that leads to increased quality can have varying effects on prices and may indeed increase price dispersion as well as price levels. All of which says that the theoretical models do not give you very clear predictions. So there's a need for empirical evidence to ask the question, what relationship is there between quality and competition? And that's what I'm going to try and answer in the rest of my talk. The empirical evidence from the US is that where prices are regulated, price competition does tend to increase quality. It's much less clear, as theory would predict, where there are market-determined prices. So we see in those markets a large amount of price dispersion within markets. We see some recent evidence that there's a very nice couple of papers just coming out that perhaps higher quality is associated with higher prices, which is overturning some of the beliefs that higher quality is not associated with higher prices, But there's also very clear evidence that higher prices are associated with monopoly. I'm going to talk mainly about empirical evidence from the UK, which has been a leader in the use of policy to increase the use of markets in healthcare. And there are various kind of components to thinking about. If you're thinking about introducing markets in healthcare, there are three kind of components where you take essentially what was a fairly centralized, regulated system and try and change incentives for providers in those markets. The first is that you want to decentralize decision-making down to those providers from government. The second is that you want to promote competition between suppliers. And the third, that in order to do that, you need to change payment systems and incentives such that those suppliers benefit from competing with each other. So you need all three components. I'm really only going to be talking here about the second component, or rather evidence on the second component. But you can see reforms across the OECD that have different amounts of each of these three components: decentralization, changes in payments and incentives, and promotion of competition between suppliers. Essentially, if you don't do the third, you might as well not have done the first and second. So the UK, as I say, has been a kind of market leader in this area and has had two experiments in introducing competition in healthcare. The first one allowed both competition in price and quality. So it allowed suppliers in the NHS to compete between each other, but to set contracts that reflected price and quality. The second was that after the first was shown to have some undesirable features, including that non-measured aspects of quality fell, whilst other aspects of quality rose, the Blair government introduced competition with regulated prices, which is essentially what I advise them to do. So the key elements of these kind of reforms when you're thinking about reforming healthcare is, first of all, freedom of patients to choose where they're treated, and I'm going to be focusing on hospital care. The second element of this set of reforms was a shift from selective contracting to administered prospective prices. So essentially, prices were regulated, and payment, though, was not related to quality. The third component, which you kind of need, is greater autonomy for well-performing hospitals. They were allowed to retain surpluses. They were allowed greater freedom over investment decisions. And the fourth, to stimulate competition, was the greater use of the private sector to expand publicly provided provision. So that you can see that within a system in which you're moving from a centralized, heavily regulated, and much loved system politically, all of these components have very political elements to them. I'm not going to really be talking about the politics of it, but you can see that, for example, the greater use of the private sector to expand publicly funded provision is accompanied by the danger that you'll have equity concerns. So that's one of the things I want to look at. So I want to say, okay, given this experiment in the 2000s by the Blair government of regulated prices and encouragement of competition between suppliers of hospital care and indeed other health care, first of all, what happened? So first of all, as an economist, you want to say, did the reforms change behavior and market structure? Because if they didn't, then you're not going to expect any impact on the outcomes that you're interested in. And then I'm going to ask, did they have any effect on outcomes, processes, productivity, and equity? So as I say, this is a fairly kind of high-level talk where I'm kind of taking you through a number of kind of outcomes. I'll mainly be looking at quality, but also a little bit at productivity and equity, because equity is a huge issue whenever you make reforms in healthcare, in any healthcare system. So in terms of behavior, if we look at what happened to patients before the reforms were introduced, compared to after the reforms were introduced, with reforms which allowed them to choose different hospitals or different doctors, patient choice was severely constrained pre-reform. The model was that you went to your local hospital or you used your local family doctor. There is clear evidence that patients after reforms exercised greater choice. So patients did respond to the incentives given to them to allow them to choose. Now, the big worry that health policy wonks always raise in this, and indeed politicians raise in this, is that all that patients are going to respond to is car park charges, or how nice the cafeteria is in the hospital. Now, both of those matter. If you're visiting a sick relative in hospital 3 times a week or 3 times a day, you do care about car park charges. And you also care about whether you can get a cup of tea. On the other hand, what you really want to know is, did patients respond to quality? And indeed, the work that I and others have done have shown that post-reform, patients did respond to quality as measured by mortality rates and distance. And indeed, some of the work that I also did showed a bigger response for sicker patients and no differences by income, despite the fact that an awful lot of political heat was raised that this would allow simply the sharp elbows of the middle classes to respond. So in terms of now market structure, what did happen to market structure after this set of hospital reforms? We did see a reduction in market concentration and significant impacts on hospitals' market shares in a way that, as economists, we would like to see. Better hospitals attracted more patients post-reform. So patients had greater choice and were choosing not only in terms of distance, which is obviously very important for this kind of good, but also in terms of quality. And it was the better hospitals that attracted more patients post-reform. I'm not going to talk. This is kind of a picture of the change in market structure. You notice that this market structure is still very concentrated. Possibly, in fact, about as concentrated as a US healthcare market, but the black line shows a shift in that concentration downwards post-reform. I won't show you this, but. So, okay, having established that these reforms did change both behavior and market structure, it's then possible to ask, okay, what effect did these reforms have? So the first and very obvious effect of these reforms was to increase corollary of paying for activity. So in most of these reforms, what happened was prices were set, and prices were not terribly related to quality. What do hospitals do in terms of regulated prices? They tend to increase the quantity of care they supply, obviously only if the average cost, which is how these prices are usually set, is greater than the marginal cost. Well, generally, the average cost is greater than the marginal cost. Hospitals tend to be reimbursed in these systems for average cost, so they do tend to increase quality. We also saw in Britain a larger role for the public sector, but interestingly, some nice work by colleagues of mine at the IFS show that this did not reduce NHS provision. It simply expanded care, which is what it was meant to do. How about, so we see increased volumes of care. How about quality, which is what's most been studied? Researchers have found positive effects for several measures of quality. There is also recent evidence of negative effects where the marginal price is above the regulated price, suggesting that hospitals are able to respond in a way that economic actors would respond. And thirdly, there's some evidence that some of the gains might have started before the reforms. In other words, you don't sort of have common trends. Productivity is probably what politicians are most interested in. Interesting, there's much less evidence. And one of the reasons is just technical. It's very difficult to kind of come up with a good measure of productivity in healthcare, which is why people tend to focus on aspects like quality, where you have arguably better measures. As I say, there's less evidence on productivity. On the other hand, it's clear that length of stay fell more in less concentrated areas, and length of stay is something that policymakers want to reduce because particularly the returns to increasing time spent in hospital as you go on spending longer are very low often. And we found no evidence of greater spending, so if you just think about productivity being kind of lower length of stay for no change in spending, you probably think there's some impact on productivity. And finally, the kind of issue that policymakers are particularly concerned about, and those in health services research are particularly concerned about, is access and equity. These reforms, whenever you introduce markets in healthcare, the argument is always that this will be fine for the rich, but very bad for the poor. There's, in fact, very little evidence of differential effects by socioeconomic status at the small area level. The waiting time gap between richer and poorer areas fell over the period, some of which may have started pre-policy, but was accelerated post-policy. On the other hand, the private sector tended to be more heavily used by individuals with higher SES, but that's actually probably less about choice and more about where those facilities were located, because the private sector is a small part of the market in the UK and operates alongside a fully insured NHS. Private sector facilities tend to be in places where richer people live. I'll briefly, I think, given time, talk about evidence from hospital reforms in other countries. So other European countries have implemented these kind of policies. Possibly the leader was the Netherlands. What have we found in the Netherlands? One of the interesting things in the Netherlands is a huge increase in market concentration. So the Netherlands had competition on both the insurer side and the provider side. You've seen consolidation, very rapid consolidation on both sides. And that's probably the dominant feature of the Netherlands market. Their evidence is somewhat limited. And again, they've seen very large rises in volumes when you introduce incentives for volume. From Germany has also introduced a number of competitive elements into its public healthcare system. The impact, again, probably the most striking impact, is the increase in hospital mergers. And there are also evidence from Norway, where the empirical evidence on hospital competition is still fairly limited. The empirical evidence on competition amongst general practitioners is that patients do respond again to quality. So, and then just briefly in terms of evidence in competition between family doctors, it's much less studied but very important. Partly because in family practitioner markets, both in the US and in European countries, there's a considerable amount of vertical and horizontal consolidation taking place, pretty much under the radar of the regulatory authorities. So if you walk down the streets in New York, and you walk from, I don't know, somewhere in the middle of Manhattan to the bottom, you will see a lot of doctors' practices, and almost all of those doctors' practices are affiliated with simply one hospital group. You can also see this consolidation from a range of European settings. However, there is general conclusions that patients do respond to quality as well as distance and waiting times. And on the other side, that providers respond to competition, but the effects are generally pretty small. So I now want to move on in the last sort of 20 minutes of my talk to talk about the flip side of competition, hospital consolidation. So I've talked a lot about the drive towards hospital consolidation that you see in many markets when you start freeing them up, or you see them in the US market, which has always had a kind of competitive structure or a free market structure. So what happens, so the question that I wanted to ask in some of my work, and there's some very nice work happening in the US at the moment on mergers as well, is what happens when hospitals consolidate? Is this a good thing? And the reason that this is kind of an interesting question is partly because you see so much consolidation in these markets, and partly because another way of running healthcare, which is currently favored by the current Chancellor of the Exchequer, is to abolish competition. So, evidence from US hospital consolidation has shown essentially what you might expect as an economist. Multiple studies have shown that hospital mergers lead to higher prices for commercially insured individuals, individuals where their insurers negotiate with the hospital chains over prices. The research on effects of quality of care tend to be limited, but there's a very nice recent review that shows that, and study that shows that hospital acquisition by another hospital or another hospital system is associated with modestly worse patient experiences and no significant changes in readmission or mortality rates, both of which are measures of quality. And the effects on process measures of quality are inconclusive. So there's some evidence that patient experiences become worse and not much evidence that quality becomes better following mergers. And these findings, I think, challenge the argument that hospital consolidation all improves quality. It's well known it'll increase prices, but the arguments for consolidation are that it will increase quality. In fact, there's relatively little evidence from the US that it will. What about evidence from the UK? So the nice thing about the UK is they do introduce lots of policy experiments. And in between the first policy experiment that promoted competition under a Conservative administration under the Thatcher, post-Thatcher Conservative administration, and the Blair administration 10 years later, was that when the Labour government came in, they said, competition in healthcare is a really bad thing. It's really bad for equity. In fact, I've shown you that it wasn't bad for equity, but they believed that it was bad for equity. So they said, we will have no more hospital competition. We will instead encourage consolidation between hospitals. And so between 1997, for policy reasons, and 2003, England experienced a wave of hospital reconfigurations designed to take both capacity out of the market and to reduce the amount of competition, or abolish. They abolished competition, but to take capacity out of the market. So what happened was over half the hospitals in the UK were involved in a reconfiguration. And the median number of hospitals in a local market fell from 7 to 5. That's a major increase in market concentration. What happened? So some work that I did with my very nice co-authors showed that the impact on hospital production was indeed a lower growth in admissions. So if you're wanting to take capacity out of a sector for this reason, that's a good thing. There was also a low growth in staff numbers, but no change in the ratio of admissions to staff numbers. So as a really simple measure of productivity, how much did you do for a given cost of staff? No change at all. There was no reduction in the deficits that hospitals were running, and there was no observed measures of quality that rose. So in other words, these reconfigurations, which were both politically unpopular and from an economics point of view not very desirable, or rather ex post, from an economics point of view not very desirable, were costly to bring about with very few visible gains other than reduction in capacity. Now, it may be that they weren't allowed to run for long enough, but we looked at data for up to 8 years after the reconfigurations, which suggests that you will at least have had time. We know mergers take time to work through, but up to 8 years after, you'd expect them to have some positive impact if they were going to have a positive impact. Now, they may have a positive impact on very high-tech things that require high volumes of numbers, but you can achieve high volumes of numbers in other ways than essentially merging a huge multi-product firm. Okay, so I finally want to ask, how did this set of reforms bring about gains? We as economists are interested in the mechanisms by which, having shown that there were these effects, in fact, there's relatively little study of the mechanisms by which competition might bring benefits. Though, again, a growing interest in this. And I think one insight that you might get is from a study of the relationship between competition and management. Why management? Well, I don't think I probably need to tell the audience in this room why management is becoming of great interest to economists. So with 3 other co-authors, John Van Reenen, Nick Bloom, and Stefan Seiler, who's now a co-author, a colleague of mine at Imperial, I'm happy to say, we looked at competition and management in public hospitals. So for those who don't know, this is the man from the US office, and this is Dr. Zeus. So why might you be interested in management and competition? Management has been shown to result in higher private firm productivity, and economies which are more competitive have been shown to have higher, better management. So what we do in this paper, or did in this paper, it's quite old now, we used a well-tried measure of management quality and exploited political marginality in order to get an instrument for competition to examine the relationship in English hospitals between management and competition. And what we found in this study was an association of management, better management practices with better outcomes on a range of outcomes, both quality, financial, waiting times, staff satisfaction, and regulator ratings. We found that management practices causally responded better to competition. And so we found that adding a rival hospital in a local market probably increased management quality by about 1/3 of a standard deviation, but more importantly, reduced heart attack mortality by about 10%. So increasing management in hospitals in response to the increases in competition that were running during these reforms seems to have been one of the channels, possibly, through which hospitals responded to competition. So I want to end with lessons and emerging issues. I think there were meant to be 20 minutes for questions. I'm a little over time, but not much. So I think the lessons and so I've given you a kind of whistle-stop tour of this kind of landscape, and I hope I haven't had too many words on slides for you all to be completely boggled by this, but the kind of lessons are: pro-competitive policies appear to have brought about gains for patients. There's I need to say first that there's very little actual calculation of welfare gains or not, because we only have bits of information and nobody has really attempted to kind of think about what are the overall welfare gains. But given that pro-competitive policies appear to have brought down gains for patients in terms of quality, in terms of access time, one of the things that's very obvious from the other markets is that we need market regulation to ensure that mergers do not remove all competition. It's also clear that when you allow for market forces in healthcare, both healthcare providers and healthcare insurers want to consolidate. They argue this is good for individuals because it gives them market power in bargaining. That's why some of these more sophisticated models try and look at this. It's not actually clear from the US evidence that this is true. The other thing, particularly in systems that started off from a non-competitive point of view, is that you want to ensure that market regulation is smart, that market regulation does not become command and control by another name. An example is Ukraine. Before the war, Ukraine had, for example, introduced very much this kind of system into a post-Soviet system. Post-Soviet system is all healthcare is provided by the state for free. And what you saw there in Ukraine was that there was a move with a very weak central regulator and a very weak central strategic authority that simply ended up doling out money to providers regardless of their quality, and regulating them so that they essentially became command and control again. So there's a lot of work for economists to think about smart regulation in these markets. We spent a lot of time 25 years ago thinking about regulation in the utility markets. I think we're pretty clear that regulation in the electricity market needs something done about it. But we definitely need to think about, if you introduce these kind of reforms, you need to be thinking seriously about market regulation, and that's a job of economists. In some settings like the UK, you also need to address the political issue that competition between public bodies is seen as privatization. Oddly, that's not actually seen as it in schooling so much, but it is definitely seen in healthcare. The minute you introduce competition, even if it's competition between public bodies, it's seen as privatization. The third is that we need to think more about the relationship between competition and vertical integration in healthcare. One of the reasons that the US healthcare market is argued to be so costly is because there's very little integration between hospitals or between hospitals and community-based providers like family doctors. So one of the studies, a very nice study by David Card and colleagues, that looks at whether the Veterans Association, which is essentially an NHS-type organization, is more efficient than private sector, which they find it is for heart attack patients. They argue this is because the VA has better use of vertical integration, particularly through electronic medical care records. So we need to think about the relationship between competition and ways of bringing about vertical integration that may be virtual rather than within the same organizations exploiting technology. Because poor integration can lead to higher costs and poorer outcomes for patients. As anyone who's run around an NHS hospital where people have been clutching notes and have asked you 15 times to repeat what you were ill with on every visit, you know that that lack of coordination is not good for patients. On the other hand, the challenge, and indeed in the UK, recent reforms have promoted vertical integration. They've also promoted complete monopoly. So the challenge is how to maintain the benefits of choice and competition whilst allowing for some vertical integration that you think will reduce duplication and basically benefit patients. Because there's no point in exiting a hospital and then not having any treatment once you've exited. You don't spend your life in a hospital. It's not like being at school for 15 years. Hopefully you're not in there for too long. but you need your care picked up by somebody else in the community afterwards. So the challenge is how you maintain choice, how you do design so you maintain both choice and competition whilst allowing for vertical integration. So I just want to conclude by saying that I think supply-side issues are going to be the primary focus of policy attention in wealthy developed countries. The performance of markets can have large effects on the performance of healthcare sector in many countries, and because healthcare sector is a large part of the economy, it matters. Increasing the amount of data that's around now allows economists to increasingly examine mechanisms by which markets may increase welfare. So I think in terms of inspiring folk in the room, promising avenues include the matching between patients and providers, which new data allows you to ask questions about better matching, allocation methods to increase matching. We need to understand the effect of greater information on provider behavior, the impact of greater vertical integration, and we need to understand healthcare production more. We need to get down in the weeds, exploit the great data that we have, and actually ask about incentives like networks, peer behavior, and other things on the impact of healthcare production. So at that point, I will thank you for your attention, and I'm open to questions.
Thank you very much, Carol, for that amazing review. I've learned so much, and it's a good way to start a conference by learning so much from the first session. We're now open to questions. There is one here. Wait for the microphone, please. Yeah. Can you say who you are for
Yes.
this?
Joe Grice, KCL. Presumably quite a lot of what the theoretical models predict depends on what the objective function assumed for hospitals is. Now, certainly one of the features of the early experiment, the 1990 experiment in the UK, was that the clinicians and what were newly called managers, they'd been administrators before, had different objectives. And that actually surfaced in a kind of civil war in some cases in various hospitals. Could you say a bit more about what the assumed objective function is, and whether that evolution of the battle between the clinicians and the administrators, in inverted commas, actually itself had any impact on the outputs, in the outcomes?
Thank you, Joe. For those who don't know, Joe has been deeply involved in this kind of policy in the UK. Not necessarily healthcare policy, but general health policy in the UK. So essentially, models of healthcare provider behavior tend to allow, the kind of dominant models in that setting tend to allow for semi-altruistic providers, because they recognize that providers are not just profit maximizing, but are interested at some level in provision. And that actually dates back for a long time. Joe Newhouse had models like this in the 1970s. The work that Kurt Brecher and Luigi Siciliani and others have done a lot of theoretical work on this in healthcare, particularly, and then tested it in the Nordic setting, tends to find that the results, for example, quality and competition, tend to follow through whether you have altruistic or semi-altruistic providers, though with a few knobs and whistles. The issue that you raise about competition making managers of hospitals and clinicians of hospitals operate together more, so that competition is kind of something that alters the incentives, I think is something that actually I've not seen explored very much, and is obviously an interesting feature, that when you essentially have multi-product firms with everybody kind of having different kind of empires within them, whether the external changes and some of the to a market change internal structures. We did, of course, though, also find that management improved in the NHS market with greater competition. what we didn't find, and that led to higher clinical quality, suggesting that incentives were more aligned, but we never tested it explicitly.
Thank you. There's one here. Oh.
Thanks. Lindsay Macmillan, UCL. Hi, Carol. So what can we learn from the education sector and from your past experiences with the Blair government to try and keep competition in healthcare and move away from this fear of the privatisation of the NHS?
Yeah, it's a good point, and of course you're a specialist in education, so you would ask me this. I guess, education is different in the sense that it's, well, pre-pandemic, it was very locality-based and will remain locality-based in the main. And in education, obviously, your producers are smaller and do not have the kind of tension, I think, between management and teachers in terms of, thinking about competition, trying to ally those structures. In terms of what we can learn, I think the education market is much more complicated because you get these issues that you get people move to a good school, that drives up house prices, that then means that individuals lose out because of that. Now, obviously in education, what you've done a lot of is have prices that differ for different kinds of pupils to try and overcome that. I know work has shown that does and doesn't work. But you already in healthcare can have those kind of prices. But the kind of prices that I would actually advocate in healthcare are much more prices that are related to quality, rather than prices that are not related to quality. And most healthcare systems are moving towards prices related to quality. But I do think that there's learning from those matching models that are used to allocate pupils to schools in education sector that can be thought of in terms of matching patients to healthcare providers. And that's a very nice avenue to kind of begin to look at.
I agree, matching is very important in life. Yeah, there's one right there.
Thank you, Carol, for a very insightful speech. I'm Transit from University of Bristol. I'm going to enroll my second job in Imperial College. And so my question is, so you have talked a lot about competition and quality control in healthcare. I just wonder, would you prescribe the same for pharmaceutical markets? As far as I'm concerned, like pharmaceutical markets have high regulation quality. Let's say in UK we have NICE, and at the same time we also have a lot of kind of price control.
Yeah, I don't think there's a natural read-through from this kind of market in which you have spatially allocated, space matters. This is a market in which you need to be going local, at least for some of your care. It's a very different game to thinking about regulating pharmaceutical prices. And obviously when there are some of the same issues, you do want prices to allow for innovation, which is one of the major issues in pharma. But I think there are very big picture changes in pharma that make it a different kind of area of analysis than thinking about competition between essentially state actors here, which is what we're doing, or heavily regulated competitive actors. So I wouldn't say, for example, that some of the read across that I've done from the US market I think are interesting, but probably when you actually get down to thinking about testing those or thinking about both theory and empirical models, you might not want to import them wholesale from the US. I think you wouldn't want to import these kind of models into thinking about price regulation in pharma. There are very different dynamics in pharma, and the regulation, what's happened in pharma is that the regulations in pharma have essentially decreased the window in which you can get your monopoly profits. And and coupled with a lack, pre-COVID, with a lack of any big blockbusters that pharma used to rely on, have really changed the landscape in both pharma in terms of innovation incentives and in the role of big pharma versus, for example, smaller players. There isn't really a read over into the kind of competition that I'm talking about between kind of heavily regulated state actors or quasi-state actors.
Any other from the wings? There's one from the furthest away wing you can find.
Hi, I'm Dibya Mishra from RISE. Thank you for the insightful talk. I just wanted to follow up on the question about matching. In school markets, it's pretty straightforward what the preferences of students are and what the preferences of schools are. Schools want better students and students want better schools. What is the analog for that in healthcare?
Okay, well, in the analog, it's interesting in healthcare is that people want a better match for their particular condition. Now, this is slightly problematic for several reasons. One is that people, as I say, increasingly suffer from more than one condition. Now, that would be okay if doctors could essentially be ranked in terms of being better or worse. But actually, doctors don't come in that form. We know some from there's a really nice paper by Amanda Dahlstrad, who's just out of the LSE, where she looks at doctors, family doctors in Norway who are providing digital care. So they're essentially randomly matched with the patients who ring up. What she finds is she looks at 3 simple aspects of care: whether you meet guidelines, which is important in healthcare, whether you are good at preventing hospital admissions for things that shouldn't go into hospital, and one final aspect. And she finds that doctors' performance on those aspects, individual doctors' performance on those aspects, are completely uncorrelated. So a doctor may be good at following guidelines, but bad at preventing asthma patients from having bad asthma treatment and ending up in hospital. So that's problem one. And the problem on the other side is, as I say, a patient may be both a diabetic and have a long-term heart condition. So a doctor who's good for a long-term heart condition is not good for a diabetic. On the other hand, we know from the US that having a doctor for your heart and a doctor for your pregnancy and a doctor for your diabetes and a separate one for each leads to very bad outcomes in healthcare because there's no coordination. So I think the matching models that you're thinking about in this are very subtle because you're going to match a multi-product producer with a multi-product user. So I think that the matching models in education tend to be that we all want our children to be better at school tests. It's not quite the same in healthcare. But I think that's a really interesting avenue for research to pursue. And we now have the data to allow that to be pursued as well as thinking about the models.
Very good. I think that'll probably be the last question. Yeah, no, you're here. Yeah. Hello. Where are they? He's coming. Second row.
Emilia from University of Essex. Hi, Carol. I guess just thinking about also the previous question, but in general, when you think about the issue about competition and choice, it makes me think about the role of information. So when you think about people making informed choices and how competition can, sort of make that process better, what do you actually think about the role of information in this kind of market? Because if I am a parent that wants to choose a school, I look at the Ofsted report with whatever caveat they are, but I know what I'm looking for. In this kind of market, I don't know what kind of conditions I may suffer from, and maybe my partner condition would be, and so on. And it's a lot more complex to think about, how we provide information so that people can make, optimal choices?
It is a lot more complex, but it's been something that economists have been thinking about for a very long time. In fact, this is an area in which thinking about who you obviously, in order to make markets work, need information. So I think the kind of lessons from this are, first of all, it tends to be in the US, it's the insurers and the regulators who use the information more than the consumers. And that kind of, I think, is lesson number one, that there's information. But and there are lots of early work that show that if you provide information on something and not on something else, you get unintended consequences. But in fact, the UK government, the reason that I've done so much work on the UK, and so many of my European colleagues have not done very much, is not because I have higher brains than them, but because I have better data than them. And the UK has been a leader in thinking about how to release information on healthcare provision, working for many years. I'm sure Joe knows all about this, working for many years to try and get information. It's not ideal, and we know that when you have kind of star kind of systems, a doctor who scores, 3 stars, you can have very nice regression discontinuity designs in which you exploit the difference between actually having an underlying score of 2.9 and 3.1. But the point is that this is something that's very heavily worked on, very heavily thought about. And the final thing I'll say with multimorbidity, people don't just get a condition that drops on them from above. Many individuals and many consumer groups actually have quite a lot of information about their condition because it's a repeat condition that they have all the time. So they are able to absorb information much better than an individual who essentially is going to have an experience good and has never used it before. So I think, again, this is an area that economists can do lots on, but it's not an area that's kind of completely a blank canvas and is not an area that's a complete disaster either.